item is sort of badged as a debate. We actually don't think it's a debate, so we've misled you. If you came here for that, I'm sorry. But bear with us, you're in for a treat. We've got two excellent speakers. Our first speaker is online from Toronto. It's Professor Mansoor Husain, who is a professor of medicine at the University of Toronto. He's a cardiologist, and he's done a lot of translational work to understand, to improve our understanding of GLP-1 receptor agonists as well as similar related drugs. I just need to check. So you're there. Hello? Can you hear us?
I can hear you. Good morning.
Good morning. We can hear you, so thank you very much.
It's a pleasure for me to be joining this symposium. I wish it was not remote. Here are my disclosures. So I think most of you in the audience will have seen this slide or some version of this slide, which really tries to visualize for us what we all see in our patients, which is that type 2 diabetes really is a progressive disease. The natural history of the disease really begins most often before the diagnosis of diabetes is made. Often in the background setting of obesity, there is insulin resistance, which is compensated for by increased insulin production. However, as the years go by and the seeds of subsequent macrovascular and microvascular disease are laid, we have the beta cells waving the white flag, the ability of endogenous incretins to continue to promote insulin secretion fail, and ultimately the three main parameters that I'm highlighting here are lost. Then you have an increase in both hepatic glucose production and the postprandial sugar rises, the fasting blood sugar rises, the A1C progressively rises. And silently, occultly in the background, those original seeds of micro and vascular complications have now begun. So this is indeed presented as a debate, but I would agree with our chairperson that it's probably not so much a debate as an important dialogue. As I've shown you with this progressive pathophysiology of type 2 diabetes, most of our patients require more than one treatment, more than one drug for their hyperglycemia to bring their A1C down to target. And amongst all of the medications available to treat hyperglycemia, I think everyone in the audience is already aware that the most robust evidence we have, including that stalwart drug metformin, support cardiorenal benefits are with the GLP-1 receptor agonists and the SGLT2 inhibitors. And I would, if you will, leave you with this central message towards the end, is that I personally believe that combination treatment with GLP-1RA and SGLT2 inhibitors, although expensive, is likely to be the most effective at preventing cardiorenal complications of type 2 diabetes over the long term. But of course, we're here to have a bit of fun, and we're here to pose this as a bit of a debate. And I would simply say that I've won this debate already, Niko, because you are the source of my information. And if it comes down to a debate between atherosclerotic cardiovascular disease, or how we generally think of macrovascular complications of type 2 diabetes, versus heart failure, and we just had a wonderful presentation on heart failure, I will make the point that in our patients with type 2 diabetes, notwithstanding, I think, a growing incidence of heart failure, occult, HFpEF, perhaps even HFrEF, atherosclerotic cardiovascular disease still dominates. It's still the leading cause of cardiovascular morbidity and overall mortality in patients with type 2 diabetes. And then a tongue-in-cheek statement in the next bullet point is I believe weight loss is more important than uric acid. And why did I mention uric acid? As I'll share with you what we believe are the mechanisms of action of SGLT2 inhibitors. And then finally, the most important point being is that why I win this debate is I believe that there are consistent GLP-1RA treatment benefits on MACE, in particular stroke, with more potent metabolic effects than SGLT2 inhibitors. So the information is coming from my dear friend and colleague, Niko Marx, who allowed me to co-author with him a very in-depth review in Circulation that will, I think, be coming online either today or tomorrow, Niko, hot off the press, where you are the lead author and provide much of the information that I'm going to use in this debate. It's entitled GLP-1 receptor agonist for the reduction of atherosclerotic cardiovascular risks in patients with type 2 diabetes. It's a wonderful practical guide that I think we're both proud to have published. So everyone in the audience knows that this big blue circle, in other words, people living with type 2 diabetes, is only increasing. There are hundreds of millions of patients, and that number is expected to increase further. Well, in this nice study by Einerson and colleagues in cardiovascular diabetology, they looked at 57 articles published over a 10-year period leading to 2017. And there were 4.5 million adults in these papers, and they were able to then extrapolate what the prevalence of cardiovascular disease was in these patients. And it's about 1/3. But if you dive a little bit deeper into those 1/3 of people living with diabetes already having cardiovascular disease, you'll appreciate very quickly that the majority are atherosclerotic cardiovascular disease. And really only about 15% are having heart failure. And this will hold true when we look at some of the trials of patients with type 2 diabetes with established cardiovascular disease. So a priori, if we're having a debate and we're choosing which of these two wonderful drug classes is to be used to reduce cardiovascular complications in our patients with type 2 diabetes, the prevalence of their disease burden is mostly atherosclerotic. And for that reason alone, I would posit that the GLP-1 receptor agonists are a better first choice. And I'll note that in this paper, cardiovascular disease accounted for 50% of all deaths over the study period. And the major contributors to this were coronary artery disease and stroke. Later in this meeting, you'll hear from the wonderful Peter Libby. And this diagram from Peter and Jorge Plutsky remains relevant today, 20 years later, is that when we think about what causes atherosclerotic cardiovascular disease in our patients with type 2 diabetes, it's obviously multifactorial. I won't go into every facet of this beautiful slide, but I want to draw your attention to the important role that inflammation plays, that thrombosis plays, and the traditional risk factors like blood pressure and lipids play. And if you just keep that in mind, and then we move on to what are the effects of SGLT2 inhibitors versus GLP-1 receptor agonists on this pathophysiology, I think you'll come to the same conclusion I have, is that GLP-1 RA provide a really interesting opportunity to affect more of these risk factors. So here's a lovely diagram. Again, I was privileged to be a co-author on this review in Circulation about how SGLT2 inhibition achieves its effect. Let's keep in mind that this is a glycosuric and natriuretic activity profile. Yes, there's a bit of negative calorie balance and some small amount of weight loss, and via this presumed loss of epicardial fat or other visceral adipose tissue, perhaps some decrease in inflammation, but this agent is not a direct anti-inflammatory. There is definitely a decrease in plasma volume and this wonderful concept of improving tubuloglomerular feedback, which I think is central to its renal protective effects, which are truly profound. And of course, here's my tongue-in-cheek comment about decreasing plasma uric acid by increasing uricosuriac effects. And whether this really affects atherosclerosis and vessel stiffness is, I think, debatable. Whereas if you contrast this with the mechanisms of action of the GLP-1 receptor agonists, again, a classic pleiotropic hormone acting on all the targets of the endogenous GLP-1, be they receptor-driven, or as I have often posited, some are receptor-independent, but they include the kidney, the heart, the coagulation and platelet activity, the gut, and direct anti-inflammatory effects that I and others have been able to show in preclinical studies, and there are some supportive data from the clinical trials using these agents, and direct effects on blood vessels, and of course on the brain, which is believed to be central to the weight loss inducing effects. And over here, if we just focus on the heart and the blood vessels, again, decrease in inflammation, improved endothelial function, improved plaque stability. Without giving you the background clinical information, this lovely review by Drucker and colleagues highlights both the preclinical, but now emergingly more clinical evidence supporting these effects. So now, what about contrasting these metabolic activities of these two agents? So here in this review by Nock and colleagues in Circulation, whether you look at the short-acting or the long-acting GLP-1 receptor agonist studied here, if you look at A1C, systolic blood pressure, lipids, body weight, yes, there is this small increase in heart rate and changes in LDL cholesterol, and contrast them, which data I'm not showing, but are for the SGLT2 inhibitors. In every category, the effect of GLP-1 receptor agonists are more potent on hyperglycemia, on weight, on blood pressure, and there's an improved, small, but improved lipid profile not seen with the SGLT2 inhibitors. Now, are the data we have from cardiovascular outcome trials relevant to our patient populations? And I would say that they are. Here is a summary of the 8 studies we have to date with a GLP-1 receptor agonist in patients with type 2 diabetes at high risk of cardiovascular disease. I won't go through everything, but I think we'll all agree that a mean age of 60, 30%, 30 to 40% female, mean body mass index of above 30, diabetes durations as low as 9 to as high as 15 years. This is pretty reflective of our patients with type 2 diabetes who have underlying cardiovascular disease. A range of A1Cs between 7 to 8.9. And then, of course, by design, large percentages of patients with established CVD, although in Rewind, 2/3 of the patients did not have established CVD. And as I mentioned before, history of heart failure ranges from a low of 9% to a high of 24%, which would fit with sort of prevalence studies of patients with type 2 diabetes. Well-controlled blood pressure, and then my final point is being the eGFR, not bad mean, but keep in mind that declining eGFR will reduce the efficacy of SGLT2 inhibitors. Here are the summary results with MACE. Whether you include ELIXA, which some people would say is more of a post-acute coronary syndrome study, or not, take away exenatide or lixisenatide in that study, and you have very consistent effects on MACE, CV death, myocardial infarction, all-cause mortality, even incident hospitalizations for heart failure, and even kidney outcomes, which most people don't immediately think of when they think of GLP-1 receptor agonists. Here is the one lovely summary figure from Niko's paper in Circulation, which is summarizing these data and adding stroke, which I haven't yet mentioned, a very robust and significant 17% reduction in stroke, not seen in the SGLT2 inhibitor studies. Yes, there are some side effects, we're all aware of them. GI side effects range between 15 to 20% of patients, but they can be managed by good advice around how to decrease meal portion sizes and to tell them that most of those side effects wane over time. The patient profile best suited, we believe, is atherosclerotic cardiovascular disease, overweight and obese patients because of the weight loss, and those, of course, at high risk of stroke. And starting with a low dose, increasing the dose slowly, and adjusting other hyperglycemic medications accordingly. Let me end then by what I do believe will be the more likely outcome as we begin to treat our patients and as the costs of some of these drugs come down, will be combination treatment. There's logic to this. If you think of what SGLT2 inhibitors do versus what GLP-1 receptor agonists do, there's some complementarity, particularly around metabolic effects. And some clinical studies have suggested potency perhaps, if not synergism, on metabolic effects by combining the two agents. So there's some great logic to joining when you can't beat the other. Thank you very much.
Mansoor, thank you very much. What I would suggest, we are going to ask Niko to answer that or complement it. And then if you are all right to stay online, we have some questions for both of you after that.
He disappeared already. He knows why. Okay.
Right. Niko, I'm not sure how much of an introduction you need after this, but you are a professor of medicine, cardiologist at the University of Aachen. Very, very long list of appointments, of prizes, of positions, and we are very much looking forward on your take of this. Thank you very much.
Yeah, thanks, Stephanie. Thanks, Derek. Thanks, John, for the invitation. And this is my conflict of interest slide. I do have interaction with various companies in the field, and I have a second conflict, or more important, a conflict of interest. And you've seen that slide already. Mansoor is a good friend of mine, and we co-authored this one together. But I understood the good English tradition is to have a debate, so I'm supposed to make the case for SGLT2 inhibitors. And I'll do that, I promise. Mansoor, I hope you can hear me. The evidence is overwhelming for SGLT2 inhibitors, and so I start with the take-home messages. Patients with diabetes, SGLT2 inhibitors reduce cardiovascular events. Heart failure patients, SGLT2 inhibitors improve the prognosis in all heart failure patients, irrespective of the ejection fraction. We heard that. And finally, and Mansoor didn't mention that, CKD, this is a very strong point, and I see nephrologists in the room here. SGLT2 inhibitors reduce not only cardiovascular, but kidney failure risk in patients with CKD. So let's look at the evidence. There's so many studies in patients with diabetes and SGLT2 inhibitors. I could spend a whole day on showing the data, but I'll focus only on meta-analysis here. And this is looking at first MACE here in the 5 trials with SGLT2 inhibitors, and you can see here a very robust and consistent reduction of cardiovascular death, non-fatal MI, or non-fatal stroke. And in addition, and this has been mentioned before, a very robust effect on first heart failure hospitalization, again with a 32% relative risk reduction, very consistent irrespective of the trial or the drug use. So to conclude here, SGLT2 inhibitors reduce MACE and heart failure hospitalizations in patients with type 2 diabetes at high cardiovascular risk, meaning patients with ASCVD, but also those with multiple risk factors. Let's look at heart failure. You've seen the categorization of heart failure, and I will start focusing on trials in patients with HFrEF, so an ejection fraction of less than 40. And here I only show you the meta-analysis that has been mentioned before, putting together data from the EMPEROR-Reduced and the DAPA-HF trial, very consistent reduction of the primary endpoint, which is first hospitalization for heart failure or cardiovascular death, which is a very typical and characteristic endpoint in heart failure trials. And looking at cardiovascular death, the effect becomes significant here with a very robust reduction in these trials. And very important, the result is independent of the presence of diabetes, and I just picked data from DAPA-HF, but a similar slide can be shown for EMPEROR-Reduced here. And you can see patients with diabetes or without diabetes, the overall event rate here in the diabetes population for the primary endpoint is higher, but irrespective of the presence of diabetes, the SGLT2 inhibitor reduces the primary endpoint. The p-value for interaction is not significant. And so conclusion from these data, SGLT2 inhibitors are a new therapeutic option in patients with heart failure with reduced ejection fraction, independent of the presence of diabetes. The second part focuses on patients with an ejection fraction above 40. You've heard from Professor McDonough that we have 3 categories now, but at the point when we started to design these trials, we only had HFrEF and HFpEF, and so these trials refer to this patient group here. And again, this is a meta-analysis of DELIVER and EMPEROR Preserved, looking at the reduction of the primary endpoint across the range of ejection fractions here. So primary endpoint, again, hospitalization for heart failure or CV death. And you can see in the 3 categories of ejection fraction, very consistent reduction of the primary endpoint by these SGLT2 inhibitors. And then there's another meta-analysis combining all heart failure trials that have been conducted with SGLT2 inhibitors, the 2 DAPA trials, the 2 EMPA trials, and then SOLOIST. SOLOIST was a little different, was a study with patients with type 2 diabetes and acute hospitalization for heart failure with sotagliflozin, which, as you might know, combined SGLT1, SGLT2 inhibitor. But as you can see here, very consistent reduction of this combined endpoint of CV death or heart failure hospitalization across the broad spectrum of ejection fraction, so leading to the conclusion that the totality of evidence supports prioritizing the use of SGLT2 inhibitors in all patients with heart failure, irrespective of patient phenotype, meaning ejection fraction, meaning diabetes or not, and care setting, meaning patient in an ambulatory setting or patients hospitalized for heart failure. Let's come to the last part, CKD. Here we've seen trials looking at different patient populations. And you know this KDIGO table here. We've seen 3 trials, Credence, DAPA, CKD, and EMPA, kidney. And as you can see here from the inclusion criteria, Credence enrolled patients with type 2 diabetes and CKD in this range here, DAPA, CKD, patients with CKD, but also those without diabetes in this range. And 3 weeks ago in Orlando, we've seen the EMPA kidney trial, which included a kind of different patient population because it also included patients with a low eGFR, but with normal or only mildly increased albuminuria, so covering a kind of different spectrum. For the sake of time, I only show you the DAPA-CKD data here. At this point, the primary composite endpoint, which was a combined kidney and cardiac endpoint, decline of eGFR of 50% or above, end-stage kidney disease, renal or cardiovascular death, highly significant reduction of this primary endpoint with a reduction in the dapagliflozin treated group compared to placebo. And when one looks at CV death or heart failure hospitalization, this also became significant in the DAPA-CKD trial. Let's look in detail a little bit more closer to EMPA kidney. The primary endpoint was CV death or kidney disease progression. And kidney disease progression meant end-stage kidney disease, dialysis, kidney transplant, or renal death, and a decrease in eGFR above 40% or above, or eGFR less than 10%. And this is the primary endpoint, highly significant, similar to what has been shown in the DAPA-CKD trial. If you look at the components of the primary endpoint, this was mainly driven by a reduction of this kidney endpoint here, kidney disease progression, and there was a trend towards a reduction in cardiovascular death, but this did not become significant. In my mind, we can discuss that there's no difference between the 2 drugs. This difference is due to the trial design in the population, but we can discuss that later. If one looks in a different way to the components here, again, kidney progression, but adds end-stage kidney disease to cardiovascular death, this also becomes significant. The question is, does that depend, the beneficial effect depend on the presence of diabetes? And this has been looked at in a predefined subgroup analysis. And you can see here patients with diabetes, but also patients without diabetes benefit in a similar way by treatment with empagliflozin if you look at the primary endpoint. The next question was whether there are differences depending on kidney function, and this has been looked at in this figure here, looking at different eGFR values, less than 30, 30 to 45 or above, very consistent and robust reduction of the primary endpoint. P-value of interaction is not significant, but if one looks at the outcome by albuminuria, I showed you in this trial there was this population with normal or only mildly increased albuminuria, UACR less than 30, no effect. Keep in mind small numbers, and we can discuss that. But if the range is above 300, like it has been in the other trials, a very robust effect. The p-value of interaction is significant here, at least hypothesis generating that there may be some difference depending on the extent of albuminuria. So I think I showed you a lot of evidence for SGLT2 inhibitor, but to nail it, I show you a meta-analysis published in Lancet 3 weeks ago, along with EMPA-Kidney, looking at the 13 large trials with more than 90,000 patients and participants without diabetes, 16,000, though the trials in the diabetes population, heart failure, and chronic kidney disease. And this is the summary figure. It's a busy slide, but I'll guide you through this slide because it really underscores the overwhelming evidence. Looking at patients with diabetes at high cardiovascular risk, looking here at kidney progression, acute kidney injury, and acute kidney injury is an efficacy endpoint here, not a safety endpoint, or heart failure hospitalization, you can see a very robust effect of SGLT2 inhibitors. If you look in heart failure patients, dichotomizing them in patients with or without diabetes, again, very robust reduction in kidney disease progression, in heart failure hospitalization, and also true in patients without diabetes. And then finally, the kidney trials, putting together here with the low eGFR patients with or without diabetes, very robust reduction of kidney disease progression, but also heart failure, and to a similar extent in patients without diabetes, kidney disease progression, but to a lower extent heart failure hospitalization. But look here, the overall rate in the placebo group was also lower. So over the last years, we learned that there's a very strong and complex interaction between heart failure, diabetes, and chronic kidney disease, which is not understood completely so far, but there's a lot of interaction. And each of these morbidities or comorbidities influences the prognosis of the patients. But I think I convincingly showed you that SGLT2 inhibitors act here right in the center of this very complex interaction. The mechanisms are not fully understood yet, but I think it's fair to conclude from my talk that there's overwhelming evidence that SGLT2 inhibitors are the most effective agents to reduce CV risk as well as kidney failure risk. Keep in mind, Mansoor didn't really talk about that, in patients with type 2 diabetes and cardiorenal disease. And with that, I'd like to thank you for your attention and happy to discuss this.